So we're going to talk about different types of triage. We're going to talk about emergency triage and how it differs from disaster triage. And I'll just a little touch on what your responsibilities might be as the nurse in the emergency room. I have to cover some stuff on bioterrorism that's required by the state of Connecticut to talk about our plans and procedures for disasters and bioterrorism. So there is a bioterrorism handout on Blackboard. You are responsible for the information on that, but I'm not going to ask you specific exam questions about drug dosages and that specific. But knowing which are the Category A agents is what you're going to need to know for exam purposes. But first we're going to talk about emergency triage. There's 5 levels according to Pellico. There was 4 levels in IGI. Your hospital may have 3 levels of in terms of triage. Resuscitation, Pellico talks about that. This is the patient who is dying. This is the patient who requires all of the resources that you have available in your emergency room to provide care for them and to basically resuscitate them. So the triage is categorized based on their clinical presentation and how many resources, what extent of the resources that are available in the emergency room are going to be needed to take care of that patient. So the emergent patient is that patient who cannot wait for care to be provided to them. They need to be seen immediately. So who do you think are some examples of emergent patients? A stroke. Cardiac arrest. That would be your resuscitation. Suspected MI. So if you come into an emergency room with chest pain, if you've ever come into an emergency room with chest pain, you told them you have chest pain, boom. You are right into the emergency room. They don't even wait around in triage for very much. So chest pain, respiratory distress, actively seizing, things like that. Urgent. These are patients who require 2 or more resources that are available in the emergency room. They can wait a little while, but not very long. So asthmatics that are not in severe respiratory distress would be an example of an urgent. A seizure patient who is maybe in that post-ictal stage. Any complex soft tissue injuries, fractures, abdominal pain, kidney stones, all those things are considered urgent. Then you have your non-urgent, the ones that need to go to the emergency room, but they can wait. And if you live in a city like Springfield and you come in with a strain or a sprain or a simple fracture, you may end up waiting for hours. The time that I had my episode of vertigo and by the time I got to the ER, I was having chest pain. I didn't have to wait very long. But I'm sure the wait would have been just enormous if it had not been for the chest pain. Minor injuries, minor in terms of triage, probably shouldn't even be at the emergency room. As the discussion I was just having with Michelle about people who, use the emergency room as their primary care physician. And yes, that is, a huge frustration. And one of the things that Romney Care in Massachusetts was supposed to stop when we were all required about 5 or 6 years ago to get health insurance. And any time that I have been in the emergency room at either Mercy or Bay State since Romney Care was instituted, I still see the same crowds of people that are obviously not in the urgent, emergent, or resuscitation phase that are still coming into the emergency room and using it as a walk-in clinic. If you are the emergency room nurse, there's 2 stages of assessments that you're going to do. And we talked a little bit about this when we talked about our patient with the spinal cord injury. And we have primary survey. That is what the triage nurse and the nurses that are going to be doing for that patient when they initially come into the emergency room, where we identify and stabilize any life-threatening injuries or situations or conditions. So it's the ABCD. And it's done usually in a couple of minutes. So it's that initial assessment. We make sure that we stabilize their airway, their breathing, their circulation, and then we do a quick neurologic assessment, either a Glasgow or the AVPU, alert and responsive to voice, responsive to pain, or unresponsive. So getting that baseline quick neurological assessment is part of primary survey. Once we've addressed and corrected any life-threatening situations during primary survey, then we go into secondary survey. And then we get that complete head-to-toe assessment of the patient. And then we're going to be doing things like the labs and the x-rays and the scans and putting in Foley's and NG tubes and those sorts of things. That's part of secondary survey. That's after we've corrected and addressed any life-threatening situations. Now, one of the things that she talks about in the book, she talks a little bit about airway obstruction. We're not going to go over that in class because you can look at that under respiratory disorders and also review things that you've learned in your CPR courses in dealing with respiratory obstructions. Same thing with hemorrhage. We talked about that when we talked about shock and critical care, so we don't need to go over that again for this unit. Trauma, fifth leading cause of death in the United States, often associated with drugs and alcohol. And so one of the issues that we have with trauma are the long-term costs that surround a trauma situation. So what are some of those costs that are anticipated with a trauma case? Surgeries, emergency surgeries. Long-term care, rehab. So traumas can be very expensive. And when we talk about things like mandatory seatbelt laws, mandatory helmet laws for motorcycles, a lot of people say, why is the government telling me how to live my life? They shouldn't be able to tell me that I have to wear a seatbelt, that I have to wear a helmet. And you may or may not have your own, you may or may not have your own personal opinions on that, but always think of what the costs are to the healthcare system when you have a patient who suffers trauma, again, usually as a result of drugs and alcohol. One of the things that you may have to do as an emergency nurse is be concerned about things like collecting evidence in cases that come through your emergency room. Things, because of traumas, you've got, car accidents, gunshots, stabbings, things that might have criminal implications or civil suit implications, and you need to be aware of how you collect and treat that patient and collect that evidence. Documenting thoroughly any wounds and other issues that the patient might have, because again, with traumas or suspected abuse, you may need that documentation if you get called into court or the chart gets called into court. Some of the types of trauma that you're going to see in an emergency room, intra-abdominal traumas, can be blunt injuries or penetrating injuries, and oftentimes those blunt force injuries are difficult to assess, and you may not be aware of what's going on and what type of injury that patient had. The gunshot, the stab, you're very well aware of what's going on with bleeding and open wounds, but blunt injuries can be very difficult for you to diagnose. What are some of the assessments? Oh, first of all, what are the signs and symptoms of peritonitis? A board-like abdomen, a rigid abdomen. What else? Pain, particularly if they cough. The patient guards or protects their abdomen. And what assessments might you do to detect whether or not the patient has abdominal trauma? CAT scans. What else? Palpation. What else? Gastric lavage to detect. Remember we talked about that when we were talking about hemorrhaging? Yes. Okay. Foley catheters. Because if you get blood in the catheter, then that could be an indication of bladder damage. And FAST, what does that mean? That's a stroke acronym, but what does it mean when we talk about intra-abdominal trauma? Focused assessment for sonographic examination of the trauma patient. So it's an ultrasound of the abdomen. Can somebody shut that back door, please? So it's an ultrasound of the abdomen that gives a greater than 90% accuracy of the presence of intra-abdominal fluid or blood. Liver trauma can happen, particularly with motor vehicle accidents, often result of blunt force traumas. Massive blood loss. How are we going to diagnose liver trauma? Ultrasounds or CAT scans? What's our treatment? Surgery to repair it, and usually blood transfusions. So this is a lacerated liver. The liver is extremely vascular, a lot of blood loss. I'm not sure if that is a post-mortem picture or if that's one that they're going to try to repair, but it looks pretty bad. In the emergency room, you might have patients presenting with poison ingestion. So our goal is to remove or dilute what the patient has ingested, but what do we need to do with corrosives? Anything that they've ingested that's corrosive. We do not want to induce vomiting with that. So we want to give water or milk to dilute the poison, but make sure that we don't induce vomiting. For the non-corrosives, what should parents always have in their home? Syrup of Ipecac. If the patient is unconscious, however, we are not going to give them syrup of Ipecac. We're going to do gastric lavage, charcoal to absorb the poisons. And if we know what the poison is and there are antidotes or antitoxins for that, then we can administer those. Can't turn the page here. Carbon monoxide, we talked a little bit about that when we talked about our burns. What are the signs and symptoms again? Cherry red color, headaches, patient may act intoxicated, dizziness. But the book says that the cherry red color is not the most reliable indicator, nor is a pulse ox a reliable indicator. Why is the pulse ox not reliable? Yeah, it will give you a measurement of hemoglobin saturation, but it's not on the oxygen, it's on the carbon monoxide. So a carboxyhemoglobin is the best indicator and the best measure of carbon monoxide poisoning. What do we do for that? Immediate treatment will be what? Hyper O2, we need to get the patient out of the area where they have been exposed to it, get them into fresh air, CPR, and oxygen. Now, we've talked about traditional triage emergency room situations. Now we're going to talk about disasters, mass casualty incidents. And this is when the number of casualties exceeds our resources. So we've seen a lot of mass casualty and disaster situations weather-wise over the last couple of years. We can have multi-casualty where it uses multiple resources within a local area, or we can have mass casualties where the local resources are overwhelmed and we start going into state and federal resources to address the mass casualty situation. In Connecticut, what happens is the governor declares a public health emergency. So that's where, you know, you always hear on the radio anytime something like this happens, you know, the governor has called a state of emergency. And what that's supposed to do is open up the floodgates of money from the federal government, resources, other resources like antitoxins or antivenoms or vaccines and things that we might need depending on the type of public health emergency that we have. It activates FEMA, it activates the FBI if it's that type of a disaster where we think it might be a bioterrorism type of situation. So the idea is that we're going to get these resources and these things from the federal government. Now, a few years ago when there was a lot of massive flooding down at the Connecticut shore and the governor declared a state of emergency, FEMA said, oops, sorry, it's not really an emergency and you won't be getting any money from us this time. The governor can declare it, but FEMA and the federal government also have to agree. Yes? Right.
Hospital Association actually stayed here overnight. We were moving people out of hospitals and nursing homes.
Right, thinking that you were going to be able to. Available, yeah.
Unfortunately,
there wasn't it. Yeah, now Michelle, you know, is a lieutenant colonel with the Air National Guard in Connecticut, and the last blizzard, they had to, you know, because of power outages and stuff, they had to oversee the movement of nursing home residents into other facilities that had power. So that was a logistical nightmare. If there is a public health emergency declared, if you, say, are licensed in Massachusetts and you want to come to Connecticut to help out in a disaster, they will waive the requirements for you to have a Connecticut nursing license. You can come in and work in a disaster situation if you have a valid license in another state. If we have, for instance, a smallpox epidemic because of maybe a bioterrorist attack and we need to vaccinate large numbers of people, we can have dentists, paramedics, and veterinarians vaccinating people. We may, as nurses, be called on to do certain activities that may not necessarily be within our nursing scope of practice. But if we have specialized training in another area that can be used in that disaster, then they can say, okay, you can do this as long as you're doing this competently and not maliciously and, you know, causing injury. So you may see nurses doing things that are outside of the nursing scope of practice as stated in the Nurse Practice Act. But what are some of the ethical dilemmas that we might encounter as nurses in disaster situations? Right, so triage, and we're going to talk about that in a second. There's a difference in mass casualty triage as to who we treat and who we don't. Yes? Right, your own personal protection, and at what point are you going to be functioning as a nurse and responding to a disaster, and at what point are you going to say, wait a minute, I'm putting myself in danger? Yes, Michelle?
Kind of along with that, I've always thought of what I do came to me, you know, that and my family.
Yeah.
I let it happen. I wanted to make sure my kids were okay.
Right, so you have that, you have family responsibilities and you have work and practice responsibilities that might be in conflict in terms of being able to respond and do that. So, and one of the things that Kristen mentioned was talking about mass casualty triage and the decisions that are made that are very different from nursing, from, you know, emergency room triage, because in mass casualty you triage based on the greatest good for the greatest number of people. So those people who are in that resuscitative classification that we talked about in emergency, where they're on the verge of dying or require huge amounts of resources and time for people to treat them and save their lives, that person is not going to be treated in a mass casualty situation, because the goal is to treat and save the greatest number of people that you can. So there's a huge emotional, legal, ethical, moral dilemma that you're in if you're that person making those decisions. And you have your mass casualty triage categories, and you have to look at, are they life-threatening but survivable? Then that would be that red, that person that needs to be immediately taken care of. So you're sucking chest wounds, shock, pneumothorax, large chest and abdominal wounds, things that can be treated that are life-threatening. And then you have patients in that delayed category. They can wait until those immediate life-threatening casualties are treated. So those would be things like soft tissue injuries, stable wounds, abdominal wounds, open fractures, not pretty to look at, but unless they're bleeding profusely and putting the patient at risk for hemorrhage, can wait. The minimal or the green category are those patients who could wait hours or even days in a mass casualty situation. So that would be your fractures, minor burns, sprains, things like that. The patients that are not going to be treated are in that black category. Those are extensive injuries unlikely to survive. And basically what you do is you remove them from the immediate area, you provide comfort measures, but you're not going to treat them. Yes, was that your question? Yeah. Yeah, you do comfort measures, you provide comfort measures, but you're not going to do extraordinary means, because again, you've got limited resources, limited staff, massive numbers of casualties. The goal is to save as many people as you possibly can. So that person that is a triage nurse in an emergency room is going to have to kind of click their way of thinking and prioritizing when they get into a mass casualty if they're called upon to triage in that. In Connecticut, we refer to special needs populations, people who need additional help and additional resources in the case of a natural disaster or a bioterrorist or whatever. Why would elderly patients be special needs in these situations?
They don't drive.
They may not drive, so they may have mobility issues. They take longer to heal. They have a lot of comorbidities. They may you're going to have difficulty evacuating them from hazardous areas sometimes. They may be socially isolated and not even be aware of a disaster that's occurred. My home care patients, back before everybody had to get digital cable, they had the little rabbit ears on top of their TVs, and they only got channel 3, channel 30, and if they were lucky, they got channel 8, because I was in Rockville, Vernon, Enfield area. And if they lived in Enfield, maybe they got channel 22. But, if they had a power loss, they didn't know what was going on. And if it wasn't their soap operas or the mass on channel 30, they usually didn't even watch TV or listen to the radio. Why are children a special needs population? They can't really take care of themselves. They may not know if they have allergies or what meds they're on. So as Michelle was talking about, 9/11, a lot of parents were separated from their kids during that time, and they were at work, the kids were at school. So there was a lot of concerns of if kids were going to be evacuated, if they needed to be picked up early from school, if schools were on lockdown. So a lot of concerns where it comes to kids. And then the disabled, of course, are going to need additional help. If they have physical disabilities, if they have psychiatric disabilities, then they're going to maybe have higher levels of anxiety, and you're going to have to spend some extra time trying to get them calmed down, getting special equipment for disabilities. And then your book talks about what happens during and after as you deal with the people that are actually providing the care in the case of a natural disaster, caring for the caregivers. So what we have to do is, if you're involved in that type of a situation, your facility or the agency that you work for should go through these various systems to try to defuse, try to identify what stress and stressors that the staff are dealing with, try to manage those stressors. You should have debriefing situations where the organizers, the command center, is gathering data from all the people that were involved in the disaster response to find out what's happened, what still needs to be done, and again, finding out what stressors and what issues, emotional issues and psychological issues the caregivers might be experiencing. Because if you were that nurse that had to make some really tough decisions in triaging, there's going to be some long-term emotional issues that you're going to be dealing with. And then demobilization when we have large-scale disasters where they bring the people together and debrief as to how that whole disaster was, how it was managed, and then following up to make sure that the ongoing stressors and psychiatric issues are being addressed by the caregivers, because we have to be ready to do that again. That's part of our jobs as nurses and medical professionals. So any questions on the emergency, the disasters, the differences between the two types of triage? Okay, so now we're going to talk about epidemiology, and as it when we talk about certain natural disasters, bioterrorism, and other types of diseases that might come. So terminology that is used in epidemiology is endemic. So what's the definition of endemic? What does that mean? Right, so it's the normal diseases that occur within a particular geographic area at predictable times. So flu is endemic to the Northeast in the wintertime. Colds are endemic. So it's the usual frequency of diseases in an area. What about epidemic? Right, so an increase in the normal frequency of those endemic diseases, what's expected in that particular area, comes at a much higher rate. So it's an uptick. It's a higher than normal level in the population, but it's still something that normally occurs. And then you have a pandemic, which are epidemics that cover large parts of the world. And fortunately, we haven't seen a whole lot of pandemics recently. So when you're dealing, if you're an epidemiological nurse, if you're working in clinics and in emergency rooms, and things start happening and people start presenting with similar symptoms, then you're going to start asking yourself, okay, is this something I would be expecting to see at this time of year in this particular area? Is it normal but at a higher level, or is it something really unusual that's happening in our particular area? So knowing, who's been affected, where they live, or where they've been exposed, and when they've been exposed has oftentimes helped. So when we had, the Legionnaire's disease, where a whole bunch of people came down with a severe form of pneumonia, and it was men that were at a American Legion convention in a hotel, and by gathering all the data of who had been at this one particular hotel, they found that that particular bacteria was in the ventilation system, and that was why all these people had developed this particular disease. But that's where they ended up looking, because of that gathering of symptoms and people that were affected. So bioterrorism can be an issue that we can deal with. The intentional use of microorganisms, biologicals, and the goal is to produce fear and disruption in society. So everybody probably remembers the anthrax scares after 9/11. We were all concerned that there might be smallpox bioterrorist attacks. So we all, in all of our home care agencies, we had to name a person that was going to be kind of the organizer for any kind of smallpox response, and making sure that everybody was trained to do the vaccinations, and people knew if they were not, if it wasn't safe for them to be administering the vaccinations, and having that list ready to go in case we had a smallpox bioterrorist attack. So what we're looking at is we're asking ourselves, is it bioterrorism? So we're looking at those epidemiological clues. Are we seeing a lot of people presenting with some really unusual symptoms, either epidemic for that particular area or something that you never see in this area? I mean, we never see plague in this area, whereas plague can sometimes have little outbreaks in the Southwest. Unusual and unexplained diseases or deaths, ages or populations that are presenting with certain symptoms that would be unusual. So when kids would normally present, at certain times of year with chicken pox before we started using the vaccine, you expect a lot of kids to be breaking out with chicken pox. But if you saw a lot of adults coming in with lesions that looked like chicken pox, you might start questioning that, because it's rare that adults would get the chicken pox. Or you see someone getting a disease or condition through an atypical route. For instance, botulism and anthrax are usually, you get them through a cutaneous exposure. People would be presenting with inhaled botulism or inhaled anthrax. That would be an unusual route and would make you suspicious of a bioterrorist attack. So the CDC has categorized potential agents as A, B, or C. Category A are the ones that you might have a question on the exam about, hint, hint. And category A are those that are the ones that are easily disseminated, have been used as bioterrorist agents in the past, cause high morbidity and mortality. And they have person-to-person transmission, so they spread very easily. So that would be anthrax, botulism, plague, smallpox, tularemia, and the viral hemorrhagic fevers like Ebola. And one of the things that we're going to be looking at is that the patients are going to present with flu-like symptoms with a lot of these. So this time of year, if somebody comes in with cough or GI, I mean, a lot of students have been out with GI issues this semester, you're not going to be too suspicious unless huge numbers of people are coming in and the treatments, the usual treatments that we give, are not helping these patients. Patients will come in with rashes, skin ulcers, headache and confusion. Again, that can come with any case of flu that you might see with patients. So having an awareness of what those epidemiological signs are is going to be very important if you're working in an emergency room or a clinic. Chemical agents. Chemical agents, instead of using biologicals, you're using chemicals, usually combinations of chemicals, and they're used oftentimes in warfare. So they can be attached to bombs, they can be attached to, I'm thinking of drones, which is kind of scary, carrying maybe, spraying different types of agents. They've been used for centuries. In many, they used some chemical agents in World War I, like mustard gas. The Germans used that. Sarin nerve gas was released in a subway system in Japan several years ago by a terrorist group. Patients will have, they can have cyanide, which can be used as a bioterrorist, as a terrorism activity. But we had a chlorine leak up in Springfield, a pool chemical company spraying a leak, and they had to evacuate huge amounts because the chlorine gas was causing problems. But cyanide, vesicants like the mustard gas, things that will irritate the lungs. And chemical agents have the properties and the concepts, and the book talks about what's volatility, persistence, and toxicity and latency. So the volatility is the ability of that chemical agent to be vaporized. So if it has a high volatility, it's going to be used very effectively as a chemical agent in confined spaces, for instance, or spraying over large areas. If it's a persistence, if it has persistence, then it is less likely to vaporize. Obviously high toxicity, a high level of injury. And latency can be another issue, because if there's a length of time between when the patient is exposed to that chemical and when the actual effects of the chemical are felt, that can be very effective for the people who are disseminating it, that they can get out of the way of being exposed to it or being blamed for it if they're out of the area where those chemicals have been released. Now we have concerns about pandemics, concerns about flu pandemics we've had in previous years, and what we have to worry about is when we have a new highly pathogenic virus. So that bird flu that we were having issues with, that everybody was all worried about was going to be this huge pandemic issue. It was genetically unique, but fortunately for everybody, it was not easily transmitted person to person. So in order to become a pandemic, it has to meet those three conditions. The bird flu, the people that got the cases of bird flu, usually in the eastern countries, were exposed to the birds that actually had the virus and not other people. But what we have to worry about when it comes to disaster response, when it comes to pandemics, is that we don't have enough vaccines to treat everybody in even all of the healthcare people in our country. If we had, say, a smallpox epidemic, we don't have enough smallpox vaccine to vaccinate all the healthcare people, let alone the rest of the population. Yes? Not really. No. No, because it didn't affect enough areas of the world. We don't have the antivirals that we have, like Tamiflu, that a lot of our patients have been prescribed for some of the seasonal flus. They're not effective against pandemic flu viruses. So, but even if they were, we don't have enough doses of Tamiflu to treat if we had a pandemic of a bird flu, for instance. And then when we come to resources, we don't have enough hospital beds. If we had a peak pandemic week, we do not have enough hospital beds. We need twice as many hospital beds as we have now. We need 4 times as many ICU beds as we have now, and we need twice as many ventilators as we have now.
Well, look at the flu season that we had this year. It ended up being, I don't think, like an outstanding one, but yet the middle of the winter, all the beds were full.
Right. And this is, you know, and think of this, when they say a peak pandemic week, they're looking at 40% of the population either sick with that particular disease or not being able to work because they're taking care of family members that are sick. When I was a clinical director at a home care agency, we had to come up with a plan to show to the state of Massachusetts what we were going to do if we had up to 40% of our employees unable to work. So we had to figure out ways of cross-training people, of prioritizing patients, of making payroll, making billing. The whole operation of the agency had to be planned out for that eventuality. And then we had to put it in a binder, and they never looked at it, and they came for their survey. I was very upset about that. We recording? I want to. So, when we talk about frostbite, what are some of the causes of frostbite, do you think? Exposure to extreme cold. So who do you think types of patients that would be at a very high risk for developing frostbite? Military. People that are military, so people that are out in the what? What are you guys laughing about? Ice fishermen, yeah. They also need a little bit of examination up here too. But yeah, anybody who's outside in the cold, and particularly when we're talking about homeless, alcoholics, people with peripheral vascular disease, can all be at a high risk for frostbite. So patients will have pain and numbness and tingling, and then eventually the extremity becomes pale, and then they develop blisters and swelling, and that's only 24 hours of exposure. We need to rewarm them very quickly, but we don't want to rub the foot because you've already got skin damage. You don't want to rub it. You don't want to put any heat directly on it, again, because it can cause more damage. And patients are going to have a lot of pain as the circulation and as the extremity thaws out and the circulation returns. So think of it as really bad pins and needles, like when you're laying on your arm and it gets numb. And patients will develop necrosis and may have to have toes or tips of noses and tips of ears amputated and debrided. Then there is heat exhaustion, which is different from heat stroke. So heat exhaustion, usually because of dehydration, patients out, running activity in the hot weather. And the difference between heat exhaustion and heat stroke is that when the patient has heat exhaustion, they usually have a normal, they don't have a change in their mental status. So they have their usual mental status. They can become hypotensive. They can become tachycardic. And they will have a normal body temperature with heat exhaustion. So what we're going to do for that patient is to get them out of that heat into a cool area, cool them down. If we don't do that, then they can develop heat stroke, and that is a medical emergency. Patient's core body temperature will rise, so oftentimes over 105 degrees. They will have mental status changes. They will become hypotensive and tachycardic as well. They can go into renal failure or DIC if we don't treat it. And this is an emergency. We have to cool them very quickly. They may have to be intubated. They need to have, they're at risk for seizures, so they may need to have Valium or Ativan IV to reduce the chance of seizures. 80% of patients who are not treated effectively for heat stroke will die. Hypothermia, that's when we have a core body temperature of less than 95 degrees. So what we need to do is rewarm that patient. So what is one of the ways that we can rewarm them? Warming blankets. What are other ways that might be more effective and more efficient? Warm IVs. Warm humidified oxygen. Warm gastric lavage. What theme are you hearing on this? Warming and getting to the core of the body. Warming blankets are great if that's all you have. I'm not saying don't use them, but the most efficient way of rewarming that patient and getting their core body temperature up above 95 is to get something into them, like warm IV fluids, warm oxygen, warm gastric lavage. Yes?
How warm of an IV fluid would be?
Probably around maybe 98 degrees, maybe body temperature. Yeah, not so high that you're burning the veins, but yeah. And one of the things that you should never do is to throw an IV bag into the microwave. Very, very bad. Very bad. So you would probably want to get like one of those warming, like a K-pad or something, and put the IV bags in that. Insect bites and stings. What is the biggest concern that we have with these? Anaphylaxis. So we need to remove the stinger, and the best way to remove the stinger is to use a credit card and scrape in the opposite direction of how the stinger went in. Why don't you want to use tweezers? Because you could break the stinger off, and the end of the stinger is where all the venom is. So you want to get that stinger out of the patient, put an ice pack on it, because what's that ice pack going to do? It's going to reduce swelling and also cause vasoconstriction so that the venom doesn't spread to the rest of the body. Epinephrine for that patient who develops anaphylaxis. Snake bites. Yeah. If you know the kind of what the snake was, it's always good to have that information, so you can tell poison control, and you can tell the hospital to see if they have the specific antivenom. Quite frankly, I wouldn't be able to tell you what kind of snake, unless it was a rattlesnake, because that would be very easy for me to identify. Patients should keep their extremity below the heart. Why? To prevent the venom from getting into the central circulation. So you want to immobilize it and keep it below the level of the heart. If you know, again, what type of snake it is, that's very important to tell the emergency room. Spider bites. We do have venomous spiders in New England, particularly brown recluse. Very nasty. I used to have a picture of that. I don't know if I still do. Oh, yep, there it is. Brown recluse spider bite 24 hours after it happened. Necrotic tissue that is going to have to be debrided. A student was telling me a couple of semesters ago about a family member who was out doing yard work, thought he'd just gotten, like a mosquito bite or something like that, some kind of a bite on his shoulder, didn't even really hurt him. Probably about 10 hours later, he's like, wow, it's kind of feeling kind of crummy, and he looked in the mirror, and there was an area of necrotic tissue that was starting to work its way around across his scapula and over to his upper arm that had to be debrided. That was less than 24 hours, and they determined, yes, that it was a brown recluse spider bite. So prevention is the biggest thing to be concerned about with spider bites. I did give you a link for an article about lightning injuries, but what do you think is our concern with when somebody gets struck by lightning? What two body systems are most affected? Cardiac? Neuros, because they both deal with electrical impulses. So when the patient gets hit by lightning, we can have asystole, we can have VFib, we can have seizures, and frequently we will have skeletal muscle damage. So what happens? We talked about that when we talked a little bit about that when we talked about burns. What's going to get released into the body? Myoglobin, potassium. So you're going to see elevated CK, you're going to see elevated K, you're going to see elevated myoglobin. Patients are going to be at a very high risk for acute renal failure after a lightning strike. So there is a very interesting article that I gave you the link for that you can read, because that wasn't on the Mayo Clinic website. Altitude-related illnesses. There is an article that I gave you to read about acute mountain sickness. Patients who get up above certain levels, 5,000 to 8,000 feet, because of the reduction in oxygen levels, can get acute mountain sickness. They can have cerebral edema as a result. They can have pulmonary edema as a result. So what we need to do is get that patient to a lower elevation. We want to give them oxygen. We want to tell them not to be drinking caffeinated beverages or alcohol before they start mountain climbing. And we could give them a medication called Diamox, acetazolamide, which helps to increase their respiratory rate and improve their oxygenation. Diamox, and that is in the article somewhere. Yep, acetazolamide. And I think the last thing is near drowning events. And again, we have an article that I have linked to that you should read. We need to maintain C-spine immobilization with that patient that we pull out of the water. Why? Because chances are they dove into shallow water, they could have a spinal cord injury. We need to, and then what is our priority assessment after that and ongoing? Respiratory. They could have salt water, fresh water, bacteria, chlorine in their lungs, and they are at a very high risk for pulmonary edema. And that is it. So make sure you go on that Mayo Clinic website and you read these articles, because you are going to be responsible for the information.